Good morning, everyone.
Good morning.
Good morning.
Welcome to the Young ERC. I'm just going to give it a minute longer because we're starting slightly earlier. So just bear with us a moment. Right, good morning to this session. That's the Young ERC session on Saturday, the 24th of October. Unfortunately, not joining you live from Manchester, but virtually from all over the world, including Brazil, which I will tell you about in a moment. So my name's Claire Morden. I'm the current chair of the Young European Resource Council. It's really just to give you an update about what's been going on and also introduce some concepts we've been coming up with and Q&A sessions with some prominent researchers and educationalists. So the Young ERC came into being 4 years ago after I badgered Professor Jerry Nolan, I should say, about setting up a platform for people early on in their careers who have quite an interest in resuscitation. That can be from any background, paramedics, nurses, doctors, anyone with an interest about how they can get involved in research. Also, having a social network so we can link to other people in different countries. So not necessarily reinventing the wheel every time, but sharing our ideas and having some sort of young area of a body coming through with inspiration and different concepts that then can be put to some of the senior members of the ERC. Also, from our point of view, it would be nice to train alongside with more senior members and more experienced members so that we get some teaching about how we can perform as co-moderators, co-chairs of sessions, and what in the future we might be able to achieve. And that has been really successful over the past few years. Certainly over the last 3 years, we've managed to introduce co-chairs at all the poster sessions. And this year we've also been able to co-moderate sessions. So Jessica Rogers, who's the vice chair and incoming chair, has been able to chair the late night with Giants session with Jazz Saw, which was on Thursday night, alongside Maria Giorgio, who's also secretary of the Young ERC. I was able to chair late night from North America with Jerry Nolan last night, which was an interesting experience as he lost part of his internet connection. So left me to it for a little while. And that has been invaluable experience in getting exposure into large international events. And certainly as the Young ERC, I hope you'd all agree that we have met the challenge of a virtual conference this year. We have successfully been tweeting at every session through either at Young ERC or we have been tweeting off our personal accounts feeding into the ERC Twitter account. My background is I'm actually an intensive care trainee with special interest in pre-hospital, and I also do a lot of motorsport medicine. I'm going to hand over to Jess as vice chair to introduce herself.
Morning, everyone. Oh, I've got some feedback there, sorry. I'm Jess, I'm an emergency medicine registrar in London, but currently on a out of programme year living in Brazil, having some slightly different experiences. So I got involved in the Young ERC 3 years ago. So my first year, Claire dragged me along and said, come along to the European Resource Council Congress. It's going to be great. We've got a trainee section. And I set up the social media for the Young ERC and was involved in starting to get the name known. Last year, I took over as vice chair. And as of the end of today's session, I'll be taking over as your new chair. So we'll have another chat at the end of the session, but we've got some exciting ideas coming up. But for now, I think I'll hand back over to Claire to start the first session. And thank you everyone for joining us.
So before we start the first session, I am pleased to announce that we have a quiz this year. So the quiz consists of questions that have been researched and devised by Young ERC members, but is open to everyone who is watching this and also everyone at the ERC conference. There will be James Nicholson, who's a medical student representative on our committee, is going to introduce it now and tell you how to access it, and we will put it on our Twitter account. There are amazing prizes to be won, which I will let James tell you all about. Over to you, James.
Thanks, Claire. Oh, there's an echo. Someone might have their microphone on. Brilliant. So yeah, we are launching for the first time this year the Young ERC Congress quiz. It's a Kahoot-based quiz, so if you've not come across Kahoot, it's a fun online platform. We will be sharing the link for that very shortly. We're just finalising some of the questions because it includes questions based on every session from the Congress so far. So we're just getting some in from the last couple of sessions, and I'll be sharing the link out shortly. So I'll pop back at the end of this session with the link. There is a prize that's kindly been offered by the ERC that will be presented in the conference roundup, and we look forward to seeing if you can test your resus knowledge, both scientific and otherwise, from the last few days in the quiz. And we'll be sending the link out to that very shortly, so I'll pop back later with the link.
Thank you, James, for doing that. So it should be a fun quiz, shouldn't take you more than a couple of minutes. The whole idea is that the time you answer the questions gives you points, okay? So the first prize will be free entry to the Congress next year. Second prize is membership of resuscitation for a year. And the third is all the manuals and the virtual learning platforms for those manuals. So good prizes up for grabs. In the meantime, whilst that is all going live, I have the pleasure of introducing Jo Farmer, who's a psychiatry trainee in the West Midlands, but works closely with the Civility Saves Lives programmes, which some of you may or may not have come across. This was introduced to this session following discussions from last year's Young ERC about how to make an impact and how being nice to each other matters. So I'll hand over to Jo with no further ado. Over to you, Jo.
Perfect, thank you, Claire. So do you want me to set up the slides now? Shall I share this screen?
If you can, that would be lovely.
Yeah, sure. Perfect. So hopefully can you see that? Is that working?
Yeah.
Excellent. So yeah, so my name's Jo. I'm a CT2 trainee in psychiatry, actually, and I work in the West Midlands. And I have kind of been put in touch with you guys and have been asked to come and give this talk about some work that I'm involved with called Civility Saves Lives. And our Twitter and website are there for you to have a little look at in your own time. And basically what I want to sort of talk about initially, excusing the cheesy kind of stock photo, is teamwork and how everything that we do in the NHS and everything we do for our patients relies on teamwork. And initially looking at kind of what makes a good team. I'm not going to spend too long on this because this is quite a commonly talked about thing. And the example I've got there is the All Blacks, one of the kind of the greatest sports teams on the planet. And one of the things that they sort of utilize is a thing called a no asshole rule, which basically says when it's about you as an individual, it's not about the team. So together you have to kind of work as one, putting aside the egos, putting aside anything else that's going on. And this is helps form part of everything else that they utilize as part of working as a team, having a common focused goal, good communication, working together, all that kind of things. I put this question here, so good teams matter. And looking at a survey done by the King's Fund, they looked at healthcare professionals' views of whether they felt they were working in a good team themselves, and what that kind of looked like and what that kind of meant. And one of the main things they found was when people felt like they were working in a good team, there was a massive reduction in the hospital standardized mortality rate. And the numbers kind of compare to figures you see for some of the leading medications. So the impact that a beta blocker might have. It had a whole raft of other impacts, kind of both including the patients. So when they kind of felt like they were in a good team, they noticed that patients kind of picked up on that. They felt like they were receiving better care, and this meant that there were less complaints. And the staff themselves reported better satisfaction. So they felt they wanted to work, they wanted to come into work, they wanted to be part of that team, and they enjoyed what they were doing more. And this led to improved performances and then overall improved reported health of the staff involved. So put quite simply, good teams save lives. And I think that's something that's quite, generally well considered. And this is where I kind of want to elbow in civility. And I feel like work as part of a team, civility is one of these many cogs that kind of fit into this big overall machine. And incivility or civility is kind of a term that you're probably aware of. You've probably a rough idea that it probably means being nice or not being nice. But in this context, what actually I mean by when I say sort of incivility or someone being incivil is something essentially that equates to kind of mild rudeness, unsociable speech or behavior. And quite a key part of it is that it is as interpreted by the recipient or onlooker. And this is quite a difficult thing, as not all the time you intend for something to be rude, but sometimes in the context, it can be perceived to be rude. And this could be something as simple as kind of rolling your eyes, tutting when someone suggests something, talking over someone, being rude in an email, not paying attention in a meeting, kind of disregarding someone's opinions in an MDT. There's lots and lots of simple examples. What happens when someone's rude? And I think this picture kind of sums up kind of how it's very easy to feel like it's your fault. It must have been something I've done, and particularly coming from my perspective, one of the reasons why I felt so keen to get involved with this was because as a junior member of a team, it's very easy to think, oh, it's probably that because I'm not doing something correct, or I'm not doing right, or my knowledge isn't there, or my experience isn't there. And you start blaming yourself, you start worrying about what you've done. But actually, I want to use this kind of example of bandwidth to kind of help explain what I mean. So the kind of concept of bandwidth is that on a good day, when everything's going well, we can kind of keep kind of 6 or 7 things in our mind actively that we're thinking about, that we're remembering, that we're juggling, and that we can stay on top of. And this could include things like remembering that on your way home from work, you've got to pick up some milk, or on the weekend, you've got to join a Zoom for your mum's birthday. But it can also be remembering that after ward round, you have to chase up the CT scan for a patient, or remembering the next step of an algorithm of some emergency care. And when someone's rude to you, it narrows this bandwidth. So you find that all of a sudden you can only stay on top of four things, or if they're still rude to you, suddenly it narrows again, so it's only 2 things. And suddenly all you're finding is the only thing that you can think about or focus on is that person in front of you being rude. And the way I kind of think about this is, if obviously in a non-clinical setting, if someone says something to you in this kind of situation, you really want to say something back, something quick, something witty, something to kind of shift that balance, but you just can't think of it because this person is just dominating everything that you can think about. And it's only later when you're driving home that this opens back up and you're like, that's what I should have said to that person. That's what I should have said as a comeback, when your bandwidth is kind of able to kind of open back up again. So when this bandwidth is narrowed and you're in a clinical setting, so all of a sudden you're not remembering to go back to check on that patient. You're not remembering to make a certain decision, and it's impacting your ability to work. The next kind of few slides are based on some work that a lady in America has done. So she's called Christine Porath, and she looked at the impact of rudeness in an office setting, and how it was impacting office kind of productivity. And what she found was that when someone perceived rudeness, they reported a massive reduction in their cognitive ability, and this kind of fits in with this reduction in bandwidth. But it was quite a significant amount, almost 2/3 reduction in their ability to focus on a task. It didn't stop there. There were a huge raft of other impacts that this was having, and a few of the main ones I've kind of included there, such as worrying about what happened in that situation. You kind of come out of that situation, you're like, oh my goodness, what was that all about? What was going on there? And that's kind of taking you away from your work. And you kind of feel like, well, why am I doing this? Why am I here? Why am I putting up with this kind of rudeness? And it kind of starts making you wonder, are you as committed to your job as you thought? You'd obviously want to try and avoid that person if they've been rude to you in the past. Surely it's going to happen again if you come across them again, and you start thinking, okay, maybe I want to avoid that, get away from that person. And if it's someone that works in your department or you need involved in your patient care, that becomes a problem. There's a massive reduction in the quality of your work. And I think that last one's quite shocking as well. And they found that there was a 12% of people left that organisation, which is a huge number of turnover of staff. And it kind of spreads. So it's like a rock in a pond, and the ripples go out, and it doesn't just affect the person that's kind of the target of that rudeness. People observing the rudeness also were massively impacted. And you can see that there was a kind of a 20% reduction in onlookers' performance. So now suddenly it's affecting everyone else that's in that room. And if this is happening in a busy A&E department where you've got numerous other colleagues around you, suddenly the whole department's now performing poorer. And there was a huge reduction in the willingness of people wanting to help others, because if this kind of culture of rudeness is in a department, why would you want to help someone else if this puts you at risk of being the target of rudeness as well? And it carries on. And in Christine's work, this kind of related to customers, but in our line of work, it obviously could relate to patients and relatives. So there's a huge reduction in the enthusiasm for an organisation. So in business, this could mean them using a competitor, but with the NHS, we don't really have that option. So it might mean that instead they don't present to hospital because they don't want to have to deal with that problem that they had last time, or the staff was so rude and it was such a horrible experience. And they feel anxious dealing with the staff. So this might mean that a patient on a ward might not feel comfortable telling staff about a new symptom or a change in their symptoms that then could impact their care. This is where I kind of want to bring it back to teamwork, because I feel like if this exists within a team, within a department, and within a service, how can we perform well together if no one wants to work, no one wants to help each other, and no one wants to kind of, no one can kind of focus on what they're doing? There's been some research in a clinical setting, and this was quite a landmark paper. So Riskin and Erez looked into the impact of rudeness on team performance. They did this by looking at a neonatal resus scenario. So it was a randomized control trial, and the mental health, the sort of healthcare professionals were kind of split up into teams built roughly of the same experience and positions. And in one, they had an observer in the back that kind of just watched quietly. And in the other, they had an observer in the back that made mildly rude comments. And it was just things like, oh, I wouldn't have done that, or, oh, why haven't you done that yet? And what they found was, in comparison, where there was the presence of this person being rude, there was an increase in diagnostic and procedural errors. So there was an impact on the performance of that resus team. And they found that on the analysis of this, that more than 50% of that was due to the rudeness in that room. So they effectively showed that rudeness directly impacted clinical care, and particularly in a resus scenario. And more recently, last year, there's a paper released by Katz and his team looking at the impact of a rude surgeon on the performance of an anaesthetist. And I realise there's probably a fair few anaesthetists watching this now, so this is not picking on you guys, but what this showed was they compared again in kind of a simulated operating scenario, comparing the presence of a polite surgeon versus the presence of a rude surgeon, and they measured the performance of the anaesthetists against the kind of expected level. And at the end, they got the anaesthetists to report their own performance. And what we found was, as you can see, where there was a polite surgeon, you were pretty much near kind of hitting the expected performance levels, over 90%. But where there was a rude surgeon, there's a massive reduction, and you're kind of operating at kind of 2/3 the expected level. But this wasn't reported, so the anaesthetist didn't pick up on the fact that they weren't performing at the level that was expected. So not only are we not very good when there is rudeness, we're not very good at recognizing that it's affecting us, because we kind of don't want to admit that, and we don't want to kind of pay attention to that. So this is quite a bold statement, but I think it holds quite true. And that when we condone incivility in our teams, we accept poorer outcomes for our patients. What can we do? And this is quite a difficult thing, and this is not something that I'm going to come on here and kind of tell you this is how you need to behave, this is what you need to do, because we're all professionals. And what I think is the kind of ideal is that when shown something like this, you can kind of go away and think, okay, is there something that I did in that situation that actually might have come across as rude, and did that actually have any potential impact? Is there something I can do within our department or within the service that we can actually try and promote kindness, promote politeness, and create a culture that rewards this? And if that doesn't necessarily work, or if there's still sort of ongoing things, one of the things that we've found can have a big impact is based on some work done by a guy called Gerald Hickson, again in America, and it's based around cup of coffee conversations, and it kind of identifies a big gap between a rude event happening and things kind of not being done, no one raising it, no one kind of intervening, and it kind of progressing to a point where it actually involves kind of higher management intervention and kind of the ongoing risk then of kind of that person being suspended or fired. So there's this big gap, which is kind of an opportunity of intervention, essentially, where these kind of conversations happen. And they work best at a peer-on-peer level. So depending on the kind of perpetrator, if you like, matching that person to someone trained in these conversations to have this kind of very informal conversation with that person that says, you know, having a private conversation with them and just kind of checking in, seeing how they are. Because what we found is quite a lot of the causes of this kind of low grade rudeness is something's going on in that person's world that they're not aware is impacting their work. And this could be anything. It could be something in their social life. There could be something going on at home, and just kind of asking how they are and checking in on them actually kind of opens that up and acts and allows sort of that person to realize, okay, it's okay to talk about this, and we can kind of work out how this might be impacting you. And just briefly going through what happened and just kind of letting them know that actually this was kind of seen as a rude interaction, or this person kind of felt that they had an impact on them, and asking them kind of how they feel about kind of being made aware of this. And that's it. There's no kind of telling them what needs to happen, telling them they need to change. And what this kind of relies on is the kind of conscientiousness of healthcare professionals wanting to do the best for the team, wanting to do the best for their patients, and actually realizing that this had an impact meant that when Gerald Hickson looked into kind of repeat offenders, it reduced by over 90%. And if there were repeat offenders, they had another cup of coffee conversation. And again, of those repeat offenders, almost all of them weren't found to repeat again. So it almost reduced and removed almost all of the kind of rude interactions in those situations. So to kind of finish off, I like to use this picture because it kind of shows that this is from the 50s, where thinking back to the kind of TB wards where smoking was actively encouraged by the medical profession as a way of kind of getting opening up your lungs, helping clear the gunk. And, you know, if you don't smoke, maybe you should think about taking it up, you know. And obviously in the kind of following period of time after this, we've learnt that this is the wrong thing to do, and we've changed, and we've addressed our approach, and we've corrected it. I think we're in that same kind of position at the moment with the impact of rudeness or incivility on our care. Prior to 2010, there were 17 papers published in the medical profession based or quoting or referencing civility or incivility. Between 2010 and 2015, there were more than 2,000. So we're really at the kind of cusp of this information and knowledge. And I feel like we're at a very bright and hopeful opportunity now to use this information and to try and have a positive impact on the care for our patients. And there's some of my references there. Thank you very much.
Right, sorry, I couldn't get myself off mute. I do apologise. Thank you very much, Joe. That was a really interesting talk, and something I think I have to say I've been on the receiving end, but also probably I've been guilty of, if I'm honest. So I can see a lot of people nodding there, and I think it's something that, as you see, makes a huge difference on performance. I know Jess has been closely monitoring Slido. So I'll hand over for some questions that we have got coming through.
Yeah, so I'll pick up on a question here. Joe, do you think rudeness is a question of a single person issue at a time, or how frequently do you think it mirrors the whole organisation and their team's approach?
I think it's very common, unfortunately, and I think it comes from both elements. And you know, I think it's very easy to think of, like you said, Claire, it's very easy to think of examples where someone's been rude, and it's also very easy to think of examples of departments where that ethos wasn't there as well. So I think it's, you know, in kind of rough kind of work that we've done, kind of sending out questionnaires and things, we found that, you know, almost everyone can recall a recent event of rudeness. And of them, almost everyone was able to kind of identify how it impacted them and the task they were doing at the time. So I think it's unfortunately a very widespread thing, and it's very common in our work because of how stressful some of the situations can be. And it's hard to kind of take that extra split second in the heat of the moment to kind of think, I need to reword what I'm about to say because this is going to be really rude. And sometimes it's not appropriate, but what is appropriate is if you are acutely rude in that situation because of overriding patient need, you know, that person immediately needs that cannula and you've just got to tell someone to just drop what they're doing and get it done. You taking the time afterwards to go back and say, look, I'm sorry, that was a bit rude, but it needed to happen. I'm really sorry, you know, I didn't mean it personally, blah, blah, blah. Like apologizing afterwards, I think kind of builds into that ethos and can make a massive difference.
Yeah, absolutely. We've got lots of questions coming through on Slido, but I'm watching the time. So I think what we might do is move on to the next section. Maybe Joe can join the Slido and type in some comments. If he's got time, we'll share the link with you on our chat, Joe. And then we'll move on to the next session, if that's okay with everyone. So I'm going to introduce the next one. We've got a lovely question and answer panel set up for you. I'm going to let each of the guys do a quick introduction of themselves. So we'll go around in alphabetical order. So Anna, do you want to start?
Of course. Good morning, everyone. My name is Anna Bichmann. I'm currently working as an anesthetic senior registrar at the Charité University Hospital in central of Berlin, and doing HEMS work as well. Since about 2015, I've worked and did research in the UK up until 2017 and then moved abroad, kind of where I'm from, to be honest. Hence, I was able to see both services. So I'm happy to answer all the questions which you will pop through. I've had probably a non-typical research career, which most of us actually do. Initially, when you initially start, I think there's always this perfect run-through program or list pathway, which you can find on websites with, you have to do a PhD and you have to do this and you do your foundation years and then this happens and then this happens, and it actually doesn't work like that. So normally actually when you start to have a route like this, great things happen and people make a massive difference. So we'll definitely go into that. That's probably what I would tell myself, not to stress too much and just be motivated to what you're passionate about and just keep going. Thank you.
Fab, thank you. And Simon Carley next.
Good morning, everybody. My name's Simon Carley. I'm a professor of emergency medicine in Manchester, which is where we should all be. So welcome to my city. I am the representative. In terms of sort of getting started in research, do you want to answer those questions, take those questions now, Jess?
Yeah, so if you want to give us a tip on what you wish you'd been told when you started in research.
I think my tip would really be to try and find a home that you feel comfortable in, and to look for people who can support you, who've got wisdom and a track record. And within that, there's three things that I want you to sort of look for, which really come back from the principles of feedback. The first is you do want somebody who can be mentor, who will support you personally to get you through the early parts of your research. But you also need somebody who will coach you, who will actually teach you the skills or put you on a course to learn the basics of research. And then finally, and I think it's possibly the most important one, is somebody who's going to sponsor you into getting you onto projects which are good for you, that you're going to get something out, that you have ownership of, that you can put your element in. The best researchers I've ever worked with as juniors are the ones who I say, you know, I want you to go away and do this project. And they come back in a week and go, well, your project's okay, but my project's even better. I've done this, I've adjusted it. That's what I'm looking for. And that's what I think you should be looking for. Somebody goes, yeah, you go for it, make it your own, go with it. That's what I would suggest.
Fab, thank you. And next we'll move on to Ross Fisher, please.
Morning, my name's Ross Fisher. I'm a paediatric surgeon, which always confuses people in meetings like this. One of my other roles is I'm a professor of education through the College of Surgeons and Physicians in Canada. And that's something I almost fell into by interest. I suppose my point to you is if you're interested in something, then you start to become more knowledgeable about it simply by reading. And then by you doing more reading, you can end up being the person who knows more about anything than anyone else. And that's my presentation skills stuff that I just read about it because not many other people do. And whilst you're then faced with this huge imposter syndrome in all of the research that you do, and I did a master's research degree, you are not the imposter that you think you are. You are the person that you really are, and actually believing in yourself a bit more rather than thinking everyone is better than you in research is a great place to be, because your research is about science. It's not about that weird feelings you have about yourself. So that would be my advice to me a long time ago, is believe in what you're doing rather than worrying about who you are.
Yeah, absolutely. And lastly, we have Casper.
Yeah, thanks, Jess. So my name is Casper Lorsen. I'm a resident physician in Denmark, where I'm finishing up my PhD right now on resuscitation teams. And then I'm also a simulation research fellow at the Children's Hospital of Philadelphia. But due to COVID situations right now, it's mostly in Denmark. And I really think if I should start up about like what I've learned and what I would teach myself 7 years ago, when I really started this, it would be that doing research is about going where no one has ever been before. And when you do that, so it's really an adventure to do research. And when you're going where no one has ever been before, you will encounter a lot of ups and downs. You will encounter a lot of problems. And then it's really important that you have the great team behind you, because you really need the support to get through all the failures that are in the research as well.
I see a lot of nodding heads to all of those comments there. You've all obviously come at research from completely different angles and with a different background and experience. which is great to see, because not everybody fits that same box. Claire, I think, has been watching Slido. Have you got a couple of questions for us, Claire?
I have indeed. So the first question is to Simon about finding a home. So has all your research primarily been based in one place and one team, or have you moved around between opportunities? And do you think that's important to move around to get broader base of your research career?
Yeah, two aspects to that. Ooh. Two aspects to that. The first is probably when you first start off, you do need a sort of a more nurturing environment, so you'll probably work with one group. But very soon after that, and again through the principle of sponsorship, the idea of working with people in other silos. So if you're doing cardiovascular research in emergency medicine, then you need somebody who can say, you need to go and speak to this guy or researcher in cardiology or in intensive care medicine or in biochemical science or in the laboratories. And you're looking for expanding your knowledge into all the other different research groups out there. So I think that's really important. But in the beginning, you'll still have a home. And then after that, as Casper's sort of illustrated beautifully, the idea of traveling and going to work with different research groups, absolutely fantastic. Because every time you go around, you bring something to them, they bring something to you. And that's when you start doing things which are new, novel, interesting. And that's where the excitement is. That's where the problems are. That's where the difficulties are. That's where the joy is. So everything that Casper said.
Could I add something to this? The fact that in the beginning, I think a lot of people are scared to approach someone, especially if they're more senior, and also the fear of failing. And I think, especially in the research and the fact that we are so multinational and spread across with our different research backgrounds as well, is that you shouldn't be scared to approach someone. You shouldn't be scared to fail. And that happens quite a lot during the pathway, probably more than the successful elements in between. But that's how you learn, and that's how you see you're trying. And it's not something negative. It's not often negative, like has a negative connotation, this word of failing or how people perceive it. But I personally think it makes you stronger and kind of moves on, because you will always meet someone along the pathway who opens some doors or gives you new perspective, and that's worth more than actually some end result.
Yeah, and actually also to add on to that and to what Simon said, in my approach has basically been to think that if you're building a pyramid, then you want to build the base as wide as possible to get the furthest up. So really, in my beginning, I've been having the approach that I should try to go into a large variety of different research fields and different research methods, and really also the more people you reach out to, the more things you'll learn, because each mentor will teach you something differently.
Yeah, there's something to be said for getting a good base knowledge in evidence-based medicine or doing a research methods course. If you can afford the time and the cost associated with those, doing something like an MRes in the UK, which gives you a broad approach to statistical methods, research design, etc., I think is very valuable for lots of reasons. Even if you choose not to go into research later on, it's still a good thing to do.
Leading on from that is another question. Is it ever too late to start your career as a researcher? Everyone's shaking their heads, so I think that is a good answer. Does anyone, Anna, do you want to comment?
I completely, I would say 100% no, because these opportunities also come and go, even with and we have to think about the fact that we all are clinicians, or most of us are in the pathway of training, and it's the same as within the clinical pathway, where you nitpick everyone's consultant's best comments and create your own world in your own reality of how you want to become. It's the same with research. So, and that's like you have your clinical career, you've got your academic career, you've got your personal life, you've got maybe academic teaching interests and teaching elements you cover. There's so many pyramids you're building, so it's never too late, because research always also gives you another quality of life element as well. I mean, I think most of us enjoy the fact that we go to conference, we have the social aspect, we have the networking, we have, you know, all the support we get. And so it's never too late to join that group who probably shares those interests, and they develop as well with your clinical experience, because you never know what you don't know, what you will like in the beginning.
So it might be, I was going to say, it might be difficult to sort of forge, if you're starting at 55, you're probably not going to become a full-time academic. That's probably true, probably. But there's huge opportunities. I mean, in the UK, we have the national trials, the NIHR trials, which run in multiple centres. Take Recovery, the current COVID trial. That's run in 175 different hospitals. Each of those has a principal investigator and a sub-investigator and co-investigators. There's opportunities to get involved in those sort of things. And, you know, taking COVID as an example, the people I think who've been involved in the research during COVID have probably done better mentally, because we found that we're doing great things as we've gone along. It puts a lot of purpose in life, as Anna says. It's a real positive to balance some of the other pretty tough things that we're all going through at the moment.
Leading on from that, I suppose the next question is, have you always all researched or been interested in the areas you are currently researching and teaching in, or have you ever switched between? Now, I'm going to ask Ross that because he's shaked his head, so I'm interested.
No, not at all. I think that it depends on whether you consider academia as a career or academia as part of what you do. If you become more directed, as Casper is doing a PhD, then you become very specifically experienced. I have a master's in philosophy and a master's in science, so I've been in both directions. And each came at a different part of my career that was of value for that bit. So rather than feel that you have to start aged 19 at medical school thinking you're going to become a professor of X, go with what's interesting, with what's valuable. COVID is going to overwhelm our world for research for the next few years. Do what interests you. And at different times in your career, you will find different opportunities and different people. And going back to the original point, it's never too late to start. So if at the age you are now, and that's speaking to everyone, and something interests you, then start with that. Don't assume you're going to get a PhD out of it, but the first review, the first paper, that's where these things should start. It's never too late, and you can go in completely different directions.
Do you mind if I add something to this, Claire?
Go for it, Anna.
So, for example, my move was because of my personal decision as well as a clinical kind of career path, but it ripped off my connection to all my UK hub or home, as Simon described it so well, of research in resuscitation. So then I was alone at a hospital where resuscitation research isn't carried out at all. I have no mentor, I have no research group. I have maybe a couple of people who verbally say they're interested, but they're not actually doing anything. And you end up being this person who at that point already really has done something, wants to continue, and has no hub. So, and you can't always start, you can start from zero, but it still requires a team and it takes some time. So then I ended up actually doing research, which was completely irrelevant to my resuscitation career, with the urology team on like prostate cancer and nephrectomies and things like that. But it kept going, and I learned new research skills from that, publishing with them as co-author. And it wasn't the fact that, okay, it's my first author publication. It didn't matter, because they have a completely surgical way of thinking is sometimes very different to the anaesthetist. And it's just a new point of view, but you keep growing, you learn aspects. So I think, it's just good to get the opportunities, try them out and see where they get to.
Yeah, that's a great point, Anna. I think that links in with what's come up several times in the conference as well, is when people have asked about how trainees can get involved, a lot of it is you need a group, you need a team, you need to find some other people with the same interest. So thank you for raising that point. Any more questions, Claire?
I think actually it was interesting you mentioned about the teams, because a couple of questions have come through that said, we talk about getting involved in a team. Can we, as someone that's interested, just email or get in touch with someone? Would people be happy with that approach if they were interested?
100%. And if at all possible, go and meet them face to face or speak to them. Emails are okay if you're geographically separated, and that's a problem at the moment of COVID. But lots of places have research meetings, and they have academic meetings, even if they're just sort of monthly catch-ups. All of the groups that I know of would be happy to have people come along to those. I can't imagine it's any different anywhere else. I think that's a great way to get your face known and to start talking to people, if at all possible.
And yeah, and I totally agree. And I would say that what Simon just said was something that I've been told many times before when I was about to getting started, and I just really found out that it's true. You know, people are very, very open. It's very easy to reach out to people and go ahead and do it. And I would actually say that especially within resuscitation, I found out that resuscitation science is kind of like a small community, so we all know each other. And I actually think that also makes us a bit more friendly perhaps because we know that it is a small community.
That's fab. Thank you, guys. I think this session could go on for a lot longer, so maybe we'll have to set something like this up as a webinar. We'll come back to that in a little while. So Claire, I believe, has some updates for us. So we're going to go back to the Young ERC. Within the Young ERC, we have a few divisions. So Anna and Casper, for instance, are two of our research team who are involved in the committee from the research side of things. We have an education branch. We have various things going on in the background. So we've got a couple of updates for you guys on what the various people have been doing, and then we'll bring the session to a close.
Brilliant, thank you very much, Jess. So it's been a bit difficult because it's virtual, and normally as a platform, we would all come up, the various committee members, and give an update. But I've managed to collate all the updates from everyone. So, and feel free to comment on Slido or on the group chat if I am not saying the right thing from your point of view. So, as we mentioned, Anna and Casper have been involved in research, and also Anna is involved in Young Investigators as well. So really from that point of view, Casper has managed to get the buddy sheet up and running. Did you just want to mention that, Casper, as your...
Yeah, so basically we've had the idea that it should be possible to buddy up with someone else, and if you are willing to either be a mentor or that you're willing to learn and be coupled up with a mentor, that you can sign up for this sheet and take contact. So we have a Google sheet that's out, and everyone are more than welcome to fill it out.
Yeah, we're very contactable on Facebook, LinkedIn, Instagram, Twitter. We'll post the links after the session for the Google Sheet and other things on all of those. So please do sign up and get in touch if there's anything else you want from us. And
I was going to add to that, the Google Sheet is not just for young investigators or people early on their career. It's also for people bringing more knowledge, I should say, like Simon Carley, who can then, if he wanted to be interested in mentoring or being in touch, he can then put his name on there and people can be in touch that way. So it's a great system of getting involved. From the young investigators' point of view, unfortunately, the summer school wasn't able to run this year because of COVID, but again, we're having very little information being sent out. So it's something that I believe Anna's going to work on with some of the big names in the ERC about. Did you want to mention anything about that, Anna?
I think what just popped in my mind is that as young ERC, like presenter, you are left alone a little bit because you've been selected, then you're presenting and that's kind of it. And then you get lost in the bubble again, unless it's then followed through with your project. So what would be good as well is what Casper created for the mentor-mentee element is that we collect the young investigators on a platform as well, where we can exchange and maybe mentor the next ones who come in, etc., or kind of follow up from what they've learned from that event actually and how they've taken those projects further, because there are brilliant ideas out there. So again, thank you.
Thank you. And then Sabine Nebecker is our medical education representative. So unfortunately, COVID has scuppered a lot of the medical education, and really the concern lies about the future of face-to-face teaching, and also about keeping skills during this time, and both postgrads and undergrads learning resuscitation skills, and how it is going to be possible for them to keep up to date with skills and learn new skills when often it's the senior clinician who is involved in the COVID patient. So we had a discussion late last night, and we're thinking of chairing a roundtable discussion on this, and be interested to hear everyone's ideas across Europe about how they have adapted to the situation, because I know things are very different in different parts of the world. Jess, would you like to add anything to this?
Yeah, absolutely. So this is something that we're quite passionate about, is making sure that we don't end up with a whole cohort of more junior staff moving on to more senior roles within the next year or two, having missed out on a lot of training opportunities that their predecessors would have had. So it's definitely something we're going to look at from the young ERC point of view, in bringing some different ideas together in conversations. Again, if anybody has any particular ways that they're working in their hospital, we're always happy for you to get in touch on any of our platforms, and we can arrange some roundtable webinars, probably in the light of COVID.
And then, so that was from the education, and I think Sabine is going to drive that forward, but we've also got a new education member on board, who, did you want to introduce, Jess?
Yeah, so that's Chris Bishop, who unfortunately can't join us today. He's working, but he is a perfusionist in London, and is about to start a clinical fellow teaching job at King's Hospital in London. So he's agreed to come on board with us this year and try and help push us from an education point of view on what we can do to expand and help you guys out.
And then we also have our PEDS representative, and unfortunately not a huge amount has changed, again due to COVID restrictions. It's been very difficult to get any paediatric research or any links going off the ground. Not lastly, we've got quite a few committee members actually. I should say we've got a medical student representative, who's James. James, you're actually on the line. Did you want to just give us a brief update about what's been going on in the med student world? Because obviously you guys have been quite deeply affected with COVID.
Yeah, COVID's been an interesting time, I guess, for everyone, hasn't it? From a young ERC perspective, we were hoping to get lots of medical student volunteers to come and help in Manchester, but unfortunately that's not been able to happen, obviously, so we're going to look to try and do that for next year. And you know, there's not that many medical students involved with the young ERC, so actually it's great for us to kind of be involved with people a bit further down the line in their careers and learn from them and things like that. The one thing I have done is I've put together the quiz, and I have got the link for that now, so I will share that. It's in the chat, but I'll share it when we've finished in a second with everyone.
Yeah, and again, we'll share that across all the platforms so people can get involved.
Are we allowed to enter? Or is
No.
that cheating? Darn.
You're
Okay.
not there because you've seen the answers, but I'm not sure if Jess has or not.
Yeah, I don't think anyone else has seen the answers apart from James and I. So feel free to enter. It is actually a really fun quiz with some interesting answers. So we also have our social media guru, Michael Smith, who has done a fantastic job actually this year. So he's been able to utilize our Twitter platform and Instagram for ongoing education using the hashtag #ResusciTuesday, which has got a lot of evidence-based practice on it. So if you hashtag that, you'll see quite a few pages on Twitter. He's created a LinkedIn page. So if you aren't on the Young ERC and LinkedIn, please feel free to join, because it's a platform with a lot of us on there that you can link with us all. We've managed to achieve tweets in every session for the ERC meeting this year, which I think is a great achievement and one we should be really proud of. And alongside those tweets, we have been avidly collecting questions for the quiz. So again, a really good achievement from James and Michael. There is also on Instagram, I have to say I'm not cool enough to be on Insta, but if you are on Instagram, there is if the social media guru has been at your chat, there will be an A4 summary of that chat going up on Instagram, and we will put all these links up for you after this session on Twitter. And the other thing he's come up with ideas is, and a conversation about how we can engage more people in the Twitter sphere and with medical students and postgrads. And he said, do we fancy doing an ERC TikTok? And I'm going to leave that over to Jess.
TikTok is something I know nothing about, so I may have to pass that back to some of the more tech-savvy younger members of our group.
Maybe next year we could do a TikTok resuscitation to one of the Staying Alive tunes or something. But we'll park that idea, and I'll tell Michael that he can create that. The other bits, we've got a senior advisor who obviously you all know, Jerry Nolan. So Jerry has been really influential during the Young ERC formation, and has said that we have had, as a group, really positive feedback this year. We've started to raise the profile of the Young ERC, and certainly it's been a bit of a hard slog from certainly our viewpoint, but we are really making a difference, and it's great that we're all connecting. And I feel personally, I've got a lot of friends out of this, as well as great colleagues and people that I can feel really good about bouncing ideas off and moving things forward. So thank you for that. Jerry has also said this is a virtual conference, and going forward we aim to continue the virtual platform whilst having some face-to-face element. And if we have any ideas as the Young ERC, if we can be in touch and let him know. So I will ask you to contact Michael Smith as the social media person if we've got any thoughts going forward for that. And certainly if you want to get involved from the tech side, which I know a couple of you have said that you would be interested, please let myself or Jess know, and we can put you in touch with members of the ERC to do that. All it leaves me to say is I am stepping down as chair at this conference and handing over to the lovely Jessica Rogers. So Jess, I badgered into coming to first meeting. She didn't really have a choice because I think she only really knew me at the conference. So I dragged her along, and she's taken over as chair. I then take over from her as vice chair for a year until we get another chair in position, and she's bedded in. So over to you, Jess. Thanks for all your help, everyone, over the years.
Okay, I'll bring the session to a close. Just a few things to say. So firstly, thank you to everyone who joined in today watching, and also to those of you who've joined us. So Joe, who's already had to leave us, Simon, Anna, Casper and Ross. It's been lovely to have you with us. Thanks for all your advice. I'm sure people have found it very helpful. There's been a lot of chat going on the Slido, so hopefully we'll continue some of these conversations. Obviously a massive thank you to Claire. She had the vision of the Young ERC 4 years ago, when she went to Jerry and said, you know, nothing like this exists for the trainees, and he said, okay, go on then, go and start it. And it's been building every year since then. And now working in collaboration with the Young Investigator and the Research Net is going to hopefully open a lot of doors and a lot of opportunities for all of you guys watching, because that's what we're really about. We'd really like to get some more collaboration and involvement with you guys this year. So we have a lot of ideas as a committee. We're going to be having some more regular meetings. Please get in touch with us, as I say, on all our social media. We do also have an email address, which is youngerc1989@gmail.com, which might give you a clue to one of the questions if it's been included in the quiz. So go and check out the quiz. We'd love this year to be able to have some more webinars with you guys involved, some more Q&A sessions. So any topics that you want to talk about, let us know, we'll set something up. I'm going to talk to the committee about this, but we'd love to be able to give you guys the opportunity to use Young ERC to practice things. So if you've got a TED talk that you want to practice your TED talk style, if you've got something that you've done some teaching on recently and you want to, it's related to resuscitation, we'd like to try and open some doors in terms of running some webinars, some podcasts, some videos, anything that we can to help you guys to start seeing some of your faces and get you involved with each other. Remember to check out the Google Doc that we're going to do for Young Investigator and for research people, because that could be really helpful for finding you some mentors and friends in the same areas that you're interested in. And I think that's all I have to say. So thank you. You'll be hearing a lot from us, hopefully, over the next, well, months, weeks and months. And hopefully we'll see you next year at the conference, but we'll have to see what happens. But otherwise, we will see you virtually very soon. So thank you, everyone, for joining in today.
Thank you. Bye.